Good morning. I'd like to call to order the Joint State Federal Relations and International Insurance Committee. I'm State Representative Brenda Carter, and I'll be chairing this meeting. I would entertain now a motion to waive the quorum. Do we have a motion? Okay. It's been moved by who? And now a second. Okay, do I need to call the names? Okay. All right then. All in favor say aye. Those opposed? The motion is carried. Now I'll entertain a motion to approve the minutes of March 10th, 2023. Second? Okay. It's been moved and second. All in favor say aye. Those opposed? The motion is carried. We have a very busy schedule today, so let's get right down to business. We'll start by hearing presentations on some recent federal health care reform proposals. We'll hear from Joey Mattingly, Associate Professor and Vice Chair of the Research at the University of Utah, and David Root, Vice President of Government Affairs for Prime Therapeutics. We'll hold all questions until both are finished. Professor Mattingly, please go ahead.
Thank you all for, make sure, is this on? Okay. Thank you all for having me today. As she said, my name is, let me go backwards. My name is Joey Mattingly. I'm a pharmacist and health economist at the University of Utah. I also own my own research analytics firm. Real quickly, I want to share conflicts of interest. I think it's important to know where my salary and everything's paid so you understand where my conflicts are as we talk about this policy. I have research funding from the FDA, and my wife is a full-time employee of the FDA. Also, in the past 12 months, I've received consulting fees from both the Arnold Foundation and Pharma, and then I've been an unpaid consultant to CMS for the implementation of the Inflation Reduction Act. So I think it's important to get that out of the way. So I like to talk all my presentations in health policy. I always start with the basics, and it's not to insult anyone, it's just so that we're all speaking the same language. And then I'm going to jump into some federal legislation I kind of categorize as PBM focused right now, pharmacy benefit manager focused, as well as drug pricing focused, and things related like copay capping and whatnot. And then I want to hit on a couple myths, like say myth busting, if you will, and some myths that are full myths and partial myths, I guess I'll say. So I start every presentation, as I said, with some basics, and I start with the premium equation. Everything we talk about in healthcare policy and health insurance should come back to this, and a lot of members and people in this room fully understand this, that on the left-hand side, if we're talking about estimating and calculating a premium, on the right-hand side, we have things like the administrative costs of administering a plan and profit. We have things like co-insurance, co-payments. We see that what I always tell with my students is look at the direction of the signs, right? We think about math. So you see a negative sign in front of the C. That means that it's an inverse relationship with the premium, right? So as we increase co-payment, co-insurance, we can keep premiums down. If we reduce co-payment, co-insurance, we may have put pressure on the premium. Similarly, if the price of something goes up that we're paying for, it's a positive relationship to the premium, so both can go up. And then same with as we increase the units of healthcare dispensed, so maybe more patients treated or patients receiving more medication, the premium goes up. We've always got to start here, and every health policy, in my opinion, should be evaluated through this lens. Similarly, we have a drug supply chain. It really should be simplified. I try to simplify it, and I do a basic supply chain first. We have a drug manufacturer. A manufacturer sells to a wholesale distributor. A wholesale distributor distributes drugs to the pharmacies. Pharmacies distribute medications to patients. And not to get into all the acronyms this morning, although I've had to learn a lot of new insurance acronyms while attending my first NCOIL meeting. But we got a lot of acronyms in drug pricing as well. Things like wholesale acquisition costs, average wholesale price, usual and customary. When we add an insurance company or third-party payer to the mix, it gets way more complicated, right? So this is where we start seeing legislation trying to address some of these relationships. So instead of just a fee from the manufacturer going to the wholesaler, we have to consider potential rebates and discounts that may go back to the payer for formulary placement. We also recognize that there's a relationship between the payer or PBM and the pharmacy distributor and how that pharmacy is reimbursed. And again, so me as an academic, when I'm trying to estimate these things, sometimes it's hard for me to evaluate, when we talk about transparency, what's the actual price being paid, right? And then as we start talking about things like vertical integration, that's become a hot topic in the PBM space. If a pharmacy, not to pick on CVS, it's just one of the big ones. So thinking about a payer PBM that may also own a pharmacy, then how does that change the equation? So I like to start there to get some of those things out of the way. Again, that's like, I feel like those 3 slides can like earn you a PhD. So I'm trying to bring it all down to just its basics. All right, so let's talk about some of the federal legislation on the horizon. So if we talk about PBM-focused legislation, so several of the states in this room are further ahead than the federal government, in my opinion. Like, the states have really pushed the issue on regulation and PBM reform. I will say the one thing I've found interesting about this, and you look at the current bills, so the Transparency Act, the PBM Reform Act, and the Patient Act, you'll see led by Cantwell and Grassley, Sanders and Cassidy, McMorris Rogers and Pallone. I think the thing that I've been watching is just how bipartisan it is. So I always, recently I've been thanking my friends in the PBM industry for helping unite the country. So thank you, PBMs, for being able to bring Democrats and Republicans together on this issue. With that said, as you go into what are some of the provisions? So similar provisions across these bills, right? And as we're thinking about what has the chance of passing, right? If all of these bills have these similar things that we're all tend to agreeing on, we want to pass through drug rebates, so any manufacturer rebates that are coming from branded pharmaceuticals, we want to pass those on to the plans or to the ultimate payer. We want to prohibit things like spread pricing. So from a PBM perspective, they don't refer to that as spread pricing. It's risk mitigation pricing. It's differential pricing. It's basically like if I buy a cell phone, I don't pay the cost of the cell phone, right? Like, I pay the price that the cell phone company is charging me, and you can call it a spread if you want. It's their gross margin. So it's there's challenges here in terms of like if I think what we've seen cases of if you hear, oh, this one drug, the spread price is $10, but over here it's $100, and you're like, well, what's the difference? The product or the service is the same. Why is the spread such a big deal? Also, you hear things like clawbacks or direct and indirect remuneration fees. This is an area that seems to be, there's a lot of traction on as well. This is the contract with pharmacies typically have situations where if you earn $100 on a claim for reimbursement on that claim, at the end of the year, 3 to 5, 10% may be part of that contract, may be due back to the PBM. As I share with my friends in the pharmacy business, if you get rid of DIR fees, do you think your total reimbursement will be higher or lower? And the response is overwhelmingly, oh yeah, we'll probably just get less money up front. So like, I think the challenge is like, okay, like DIR is kind of a bad guy right now, but just because you get rid of DIR doesn't necessarily mean pharmacies are going to make more money. And then additionally, part of the bills, we see annual reporting. It's a little mixed on whether it'll go to FTC or GAO, and then where the reports go to Congress. So the final bill will be interesting if it does pass and get to the president's desk, what it'll ultimately look like. I want to touch on a couple different things on drug price-focused legislation. So we have the Smart Prices Act. So you'll notice here I have Senator Klobuchar leading. As of earlier this week, I did not see any Republican co-sponsors, and I don't really expect any because this bill is expanding the drug price negotiation and the Inflation Reduction Act. That's very partisan right now, and I don't know where you land on IRA and what it's doing with drug price negotiation, but it doesn't seem to me that there's a lot of support in expanding it just yet. That may change in a new Congress, I don't know. In terms of expanding access to low-cost generics, so Smith and Braun have introduced a bill to reduce the practice of parking. Parking is when a brand manufacturer essentially is agreeing not to sue the first generic company that's coming to market, so it's just kind of working on that deal to delay that release of the generic. So, I think that's something that seems to be bipartisan that folks can get around. And then another, looks like Warnock and Kennedy are behind the Affordable Insulin Now Act, which is taking that $35 cap that we saw with IRA and trying to get that to private plans. And so I want to make sure I touch on that briefly too. Now, I couldn't understand, I dove in, and this is where it's like, I don't know how many degrees I need to figure this stuff out, but like figuring out like how are we actually going to pay for that, that to make sure that capping the price isn't necessarily like what's it going to do back to the premium, like what's it going to do to the ultimate, like what we're paying for it if it's not actually lowering the price of insulin. So that's when I want to jump into myths, make sure I'm doing okay on time. First myth. So I want to talk about PBMs first. When I see the term middlemen, I immediately think you're either biased or you don't know what a PBM does. And that's just how it is. So when I saw the FTC headline, deepens its inquiry on prescription drug middlemen, I said, oh, well, either the FTC is biased right now or it doesn't fully understand what a PBM does. To lump them into a pejorative term like middleman is totally like ignoring the service that they've done and developed over 70 years. I think the first PBMs in the early 60s, late 1950s, and have evolved on services that we asked for. Second, vertical integration is always bad. It's always like, oh, vertical integration is like all this terrible thing. Does anybody own an iPhone? Anybody own an iPhone or Apple product? This company has built a multi-trillion-dollar company off of a vertical integration model. Vertical integration in itself may or may not be a bad thing. We need to evaluate when vertical integration may or may not hurt consumers, right? So the real question should be, when is vertical integration bad? So maybe it's not a myth, maybe it's a partial myth. Third, PBMs are not transparent. This seems to be a big kick about like, we just need more transparency, more transparency. I showed you a supply chain earlier, manufacturer, wholesaler, pharmacy, PBM. If we're asking for transparency from the PBM, so PBMs are responding to requests for proposals. They're responding to what payers and employers want. I believe that they're transparent with their customers. They're saying, okay, we responded to what you want, so put it in the RFP if you want it. I think PBMs will respond to that. So I think they are transparent with the agreements that they make. What's probably challenging is as a general public, like, it's so convoluted, like what we're paying for and what we're getting. And I'm always frustrated that I don't know, again, how many degrees do I need to understand my benefits? Like, I don't know if I can get another degree to understand this anymore. And it's still confusing when I go to the pharmacy or even in October when it's like sign up period for your new, for your new plan. So maybe that's things that we need to work on and how we talk about transparency. And then what's the role of transparency for the other members of the supply chain, pharmacy, wholesaler, whatnot. Drug price myths, I'll cover these and then go ahead and pass on to the next speaker. Myth one, and this might be controversial, maybe it's a partial myth, the U.S. pays too much for prescription drugs. I've done analyses on brand and generic drugs, and the biggest misnomer is that we pay the most for drugs. For generics, we pay the lowest of our comparator countries, OECD countries. We have for many, many years. But what we've done in this country, we've made a trade-off since the 1960s. That if you bring a new drug to market and we grant you a monopoly for a period of time, and then you charge us monopoly prices, you charge us very high prices when you have a branded product. So we see these huge prices for the brand drugs. That is true. So both are true. So we have to be careful when we throw out things like drug prices, because on the generic side, we're seeing drug shortages. Drug shortages may be a function of a supply chain that's not supported. Second, the copayment caps lower prices. They do not lower prices. They lower the price to the patient that's exposed to it. I explain copayments and premiums to my students as the copayment is a tax on the person using the insurance or the sick. The premium is the tax on the whole population. So like, I think you have to explain it that way. And so if you're not doing something to lower the actual price, then the copayment cap isn't necessarily lowering prices. And third, price transparency will lower prescription drug costs. I'm sorry, this is also a myth. If you have a rare disorder that can only be cured by a certain drug, your demand for that drug is inelastic. It does not change, and so you will pay whatever it takes to get that drug. If you are having a heart attack and you get into the ambulance and the EMT pulls out an iPad and starts giving you prices for the nearest hospitals, your decision-making is not going to change a whole lot. Get me to the first hospital that can fix my heart. So my point is, some drugs actually do have elastic demands and price transparency can help, but some drugs it's not going to matter. So with that, I know there's a lot of stuff in a few minutes, but I want to make sure the other speakers have plenty of time.
Thank you so much for that. And now we'll hear from David Ruth.
Oh, is that all we did?
No, I don't need the clicker, just the microphone. Thank you. Thank you very much. I appreciate the time to be here. I don't want to ruin the impact of that presentation. I feel compelled to say this. In 15 years of working in the PBM business, I have not witnessed a more balanced presentation of how the program works. So let me take a moment to say thank you. Also to make sure that I've never met this gentleman in my entire life, but I think we will be talking again soon. I think it's really important to take what you heard here a moment ago and try to derive some questions, and hopefully you'll have some questions for us. I was asked to sort of talk about the legislative state of play at the federal level, so let's go ahead and walk through that a little bit and see how that comports with what we've just heard. So here are the issues that are in play through a variety of bills. I just want to read them off to you. A ban on spread pricing, FTC regulation of PBMs, mandatory rebate pass-through, public reporting of drug price codifications, delinking of PBM's compensation to the list price, expanding FTC studies of PBMs, PBMs required to be fiduciaries, formulary tiering, pharmacy DIR, direct and indirect remuneration, which is an interesting prospect in itself because CMS fixed that last year and it takes effect next year. So it's been addressed, yet we have 5 bills in Congress right now readdressing it. And we have ERISA preemption, step therapy restrictions, issues around biosimilars, rebates for highly rebated drugs, particularly insulin, and cost sharing for insulin, some of the bills that you just saw. Those are the issues. Now, what are the rules? The rules are that you need 60 votes in the Senate to pass anything. So even if a House bill comes over, they have to get 60 votes to pass. And right now, the House hasn't been able to organize itself to make those things happen around any particular piece of legislation. And the Senate has Senate Finance, it has the Senate Majority Leader, the Senate Help Committee, are all committees of jurisdiction that are vying for their version of health care reform. Now, which one's going to come out in the wash, we don't know. And how they're going to get there, it's going to be hard to tell. There are, 14 days left between now and the August recess. I think that was like a week ago, so we're down 7 there. Then they take their August recess, and they come back, and next year starts an election year. Is there enough time to do this? Only Senator Schumer, who's in charge of the Senate, will be able to determine that. And then they have to, once they figure out the time, they have to be able to get to the number 60. We all want lower drug prices. The problem is that list of issues I just read don't represent lower drug prices. As we just heard in the previous statement, there are consequences for every action. So I love the equation. You take an equation everybody remembers from chemistry class. If you have to do the same thing on either side of the equation. If you lower the out-of-pocket costs, you're going to have to raise the premiums because none of those issues address the overarching issue. And the overarching issue is that the manufacturers are the ones and the only ones that set the list price and have the ability during the course of any given year to raise the list price as they see fit. And we have proof of that now, as we've seen over the years. The 3 major insulin manufacturers have finally come out publicly and said we're going to lower the cost of insulin to between $35 and $50, depending on which manufacturer it is. Well, come on in, guys. Join the water. We've been in that pool for the last 5 to 6 years. For the last 5 or 6 years, the majority of the members of PBM membership, whether employer groups or plans, have not paid, they've paid no more than between $35 and $55, the highest in the $55 category usually being the people in the high deductible health plan space. But we've been able to even mitigate that. The people that are exposed to the list price are the uninsured. That is a problem, but that exposure is to a price that is not set by the PBMs, and it is an exposure that is not addressed in any of those issues, in any of those bills. There have been 11 hearings in Congress so far. Not a single one of those hearings has addressed the single question, why does that drug cost so much? Why is the list price for a new drug? There's this wonderful category I like to call the Me Too drug, right? So you take a category like MS, and there are a ton of drugs in the MS category. They all have roughly the same efficacious value. They treat MS in the same way, roughly the same level of side effects and the same potential amount of side effects. But there's a new drug. And the only difference between that new drug and the other 19 drugs in that class is that the new drug costs 20% more than the last one that entered the class. And so the PBM's job is to come along and negotiate with the manufacturer and say, we want a better price. Your drug's no more efficacious than the other drugs. Give us a better price, and we'll prefer that product, and we'll help drive our members, the individuals, and the benefit sponsors to the lowest possible cost for the healthcare, the lowest possible cost for the product. That's the role that the PBMs play in the supply chain. We force pharmacies, we force community pharmacies to compete on price and service, which is directly extended to the member at the counter, and we force manufacturers to compete on price and efficacy, which is, again, inures to the benefit of the consumer. All of this legislation is being driven by those two entities because they don't want to be forced to compete. They don't like it, and I understand that, but at the bottom line is, if we don't force them to compete, they continue to drive healthcare costs up and up and up. With the manufacturers drive it up with new launch prices and ever-increasing price structures for existing drugs. And you take the pharmacies, simple question. If I take my benefit to a pharmacy today and it costs me $20 at that pharmacy, and a state passes a piece of legislation and I now go back to that pharmacy a month later and I get the same product and it now costs me $30 for that product, how has that lowered my healthcare costs? It hasn't. It's just transferred more of that healthcare dollar away from the consumer, away from the health plan, and given it to the community pharmacy. Now, there may be people here that share the attitude that we need to protect community pharmacies and we need to do this and that, and that's your right to talk about that, but I'll suggest that you need to be very careful. That's a slippery slope. If you're going to protect that group, then, what are you going to do for the used automobile salesman? Or what are you going to do for the hardware store because Walmart came to town? Or the food store because Aldi came to town, the grocery store because Aldi came to town? So you need to really think about the consequences as you go through those actions, and you need to ask yourself, are we really lowering the cost of healthcare, or are we just transferring money? And then more often than not, we're not lowering the cost of healthcare, we're just shifting money from one entity to another, and it's away from the consumers. So with that, I'd love to entertain questions. I think that would probably be very useful.
Yes, it is, and thank you both for your presentations. And legislators, are there any questions? Representative Meskers.
So I'm going to start off with an observation and then a question.
Yes.
The last comment you made was that we're transferring money around, and I wouldn't challenge you on that. That's probably an accurate assessment. But that's what we're doing now with the entire PBM and pharmaceutical money. We're transferring the money of my constituents into the pockets of pharmaceutical companies and into PBMs. And in the United States, we're paying 3 or 4 times what they're paying in the OECD countries for pharmaceuticals, which tells me that our pricing mechanism is broken, and that if I have to look at a PBM model, and I spent enough time on Wall Street to know if I can't figure out the model, someone's got their hand in my pocket. So if the model is this broken, the question is, how do we fix it? My suggestion, I'd love your response or question to, the most logical model for me is to use a negotiated price. And the negotiated price for our pharmaceutical industry versus the OECD countries is a premium to make sure research, development, and technology stays in the United States. So I don't know if that's a 20% premium over Switzerland or England or Holland, or you name the countries in the OECD, and a premium to keep the development here, but that the U.S. should no longer be subsidizing cheap European and international drug prices at the expense of our constituents. And the question is, how do we get to a transparency where I'm not paying 4 times what my Canadian colleagues are paying for drugs? Because I'm subsidizing the world, and that's research and development, stock buybacks, executive compensation, et cetera. I'm not against any of those, but I'm not sure why I'm footing the entire bill for that in the industry. And I don't think PBMs solve the problem. And all of the bills I see before Congress, I feel like they're rabbit holes that don't address, chasing me down a rabbit hole that gets me nowhere in terms of generating the fundamental problem. I thought what we did at the national level in the Infrastructure Act to require some negotiated drug prices was the first salvo in saying transparency in pricing. And I'm not sure if any of the rest of this gets to that point. And so I guess the question is, shouldn't we be negotiating our drug prices at some premium to keep the industry here? And isn't that the best way to improve the model?
That's exactly what the PBMs do, is negotiate those drug prices. The question you're asking is how, when you say that you feel as though you're subsidizing the rest of the world, that's a question to ask of the manufacturers. And in some respect, I don't disagree with you. We are. If you look at a new drug, a manufacturer brings a new drug to the world market, they have a very specific way in which they bring that drug to market across the globe, all designed to increase its, to be able to increase its price when they get to our market and North America and a few other of the industrialized countries. So we are subsidizing that. You're asking that question, frankly, to the wrong person. We would agree with you that we need a better way to make them accountable for those drug prices and to get them to be more realistic. Because I think what you're actually saying is that, for the most part, a lot of these new launch prices are not realistic. They're not. And they're not only are they not realistic, but they're not sustainable. But without our ability to leverage the lives, because that's what a PBM does. It leverages lives, and we go to the manufacturer and say, you've created this great new product, that's fine. We've got 140 million lives, and we want to be able to have that 140 million lives have access to your product. But we can only do that if you give us a better price, because your list price isn't going to cut it.
I guess that's the observation I'm making, is the PBM is trying to negotiate a drug price in a market that lacks both negotiating strength and strategy from the point of view of the fact that we're paying 3 and 4 times what OECD countries are paying. So if it was effective, and it's not an attack on PBMs, it's the structural problem. If we don't negotiate drug prices at the national level, we're always chasing some hope in the future for rational drug pricing in the United States, and everyone else is benefiting. And that's the observation.
And that's a fair observation. I would argue that, from my perspective, I would say that the PBM negotiations do work. I would say, in the interest of honesty, there's one place where they don't, and that is where we have no leverage, and that is the orphan drug status. The rare orphan drug disease where there's one drug in the class, there's no competition, and we therefore don't have the ability to leverage the two competitors against each other to get a better price. So in that respect, we do fall down as an industry. That is a place where we don't negotiate very well. Not because we can't, but because there just isn't any leverage to drive that market competition.
Senator Bidel.
Thank you. My question is about the independent pharmacies, I guess, for Mr. Root. So a little confused by your comments about the independent pharmacies. What my pharmacists are telling me is they can't afford, they have no cost of distribution. They're actually losing money when they sell certain drugs. So how do we answer them about lack of cost to actually do the distribution of the drugs?
Sure, that's a great question. Thank you. So the first answer to that is to be intellectually honest and say that, yes, they are losing money on some of the drugs that they dispense. Our reimbursement to them is designed to be, it's 2 things. It's designed to be a total basket of reimbursement, so cherry picking an individual drug where you might have lost $100, 50 cents, or even $250, serves an illustration but does not actually represent the whole. The second issue is that our reimbursement incentivizes them to be judicious purchasers of those products. Generic drugs, especially generic drugs, are available in the marketplace from a variety of different sellers, wholesalers and manufacturers. We try to incentivize through our reimbursement to make those pharmacies buy those products at the cheapest possible place so that our members can then have that savings. And when they don't, it becomes a problem for that pharmacy. And when they are not buying that drug at the most judicious location or in the best possible way, then that is causing a problem for them. But our reimbursement is specifically designed to do both of those things, because both of those things put downward pressure on the price of the product for the consumer when they're at the counter. Sorry.
If it's okay, I just wanted to add to that, because we're studying pharmacy closures in the U.S. at the University of Utah. The independent pharmacy closure situation is quite complex. In a period of where pharmacies net grew in the country from like 68,000 to 69,000 over about a 10-year period, still we had about 12% of pharmacies would close in any given year, so there's a lot of churn. Also, in my former life, I was a district manager for the Kroger Company, which had a $4 list. Every drug on that list, so if I got $4 from a patient, the drug may cost pennies, 30 cents, 40 cents. But the operational cost to put that prescription together and pay the pharmacist and pay the overhead and the technicians was typically $6 or $7. Every single product that left that pharmacy was at a loss. Pharmacies have selectively done this on purpose because when a patient comes in with their generic blood pressure medication, they might also have a more expensive product that I make $200 on. Right, and so that's probably the more just cutting to it, okay? Pharmacists, my own people, have sold at a loss strategically. And now we're seeing that differentially when your patient population changes at no, like maybe a certain drug goes generic and then it goes to that low price, all of a sudden that used to be a big moneymaker for you. It's not. And so I think what we're seeing is that as patients change, as communities change. The pharmacy that's been there for 75 years is now covering a patient population that's not profitable to them anymore. And then those pharmacies without any carrot or anything else closes. And so that's why I think it's complex. And I was also part of, during my time as a DM, we had a pharmacy in a small town in southern Illinois that closed. It was devastating for the community. So again, it's complex. The problem is when we start talking in aggregate and who's making what, and it gets lost. The nuance gets lost.
All right, Representative Bennett.
Thank you, Madam Chair, and thank you both for your presentation. I enjoyed hearing you talk about wanting to lower the cost of drugs, and forgive me, I have been educated well on the PBMs and this whole chain. I think on behalf of my constituents and consumers, I would love to see us lower drug prices significantly. And my general question, my colleague from Connecticut was much more detailed, but I struggle to understand how anyone in this chain is actively invested in lowering the cost because your bottom lines depend on it. A PBM negotiating a lower price still needs that initial price to be very high in order for them to make a profit. So I would love to know where you see the spots in this chain that are ripe for reform that will actually lower drug prices as opposed to what you said, which is true, which is moving money around.
Let's see. Well, I'll start with just briefly. You're absolutely right. Every part of what you just said is accurate. If our reimbursement to pharmacies, if our payment of drugs is a function of the drug price, every contract in that supply chain is a function of that drug price. And if you're making 3 or 4% on that product, you'd rather have it be a $1,000 product than a $20 product, right? So I really applaud you for calling that out. So if you disaggregate that, then the question is, okay, then do we do we pay a cost for the drug, and then how do we figure out what is the value of the pharmacist service? What is the value of the wholesaler maintaining a cold supply chain to make sure the insulin's not sitting in a hot factory somewhere? How do we disaggregate that? And it's messy, but I'm willing to jump into it because I think what you're getting at is really important. But one thing I have to keep going back to is our drug prices aren't always high. And if we're not willing to address patent law, if we're not willing to address that, then we're not touching that piece. And I don't know what else to say. Like that, we'll just leave it there and we'll just keep dancing around this issue of we're going to incentivize the innovation and then we're going to reward that company for billions of dollars. And then someone will say, well, what's your marketing cost? What's your R&D cost? It's not the R&D cost of that drug. The billions of dollars that go to that drug company fund the R&D for the other 20 drugs in their pipeline, and they have to pay for the failures too. So I hate it because I'm an economist that also, like, I'm calling it out. Like, I want it to be lower, but like, I also, if I get a disease that's not cured yet, I'd like there to be a product in a few years for that to be there. So unless we're willing to have that conversation, I don't know how to answer it.
Thank you. That was we played past the mic. That was a great question and actually very insightful. Just to touch on a few things, patent reform we would argue, is critical. That is something that would begin to lower the price. The pay-for-delay program that the manufacturers engage in with generic manufacturers, they actually pay them to not bring their generic to market so they can keep their branded product, their monopolized branded product in the market a year longer. And when we say like maybe a year longer, let's make sure we understand what the dollars are, right? One drug, Humira, made $4 billion last year, right? So when we talk about just 12 more months can be a lot of money, a lot of money. And they're willing to do that. We need to see FTC reform. We need to see the FDA, rather, not the FTC, but the FDA reforming the citizens petitions, another form of pay for delay that the manufacturers engage in. I think it was just at the beginning of this year or in the middle of last year, one manufacturer, in order to extend the life of their monopoly, sold the patent rights to their product to an Indian tribe because then they were going to get out of the federal monopoly law and be able to continue to be the sole proprietor for that product for another period of time. That was overturned, but they tried it. Those things have a direct impact on the list price of the product. They will lower that price. And we know, as I said before, that the manufacturers have the ability to do it. The three top insulin manufacturers just did it. And so starting, I think, in September of this year, you're going to see $35 insulin. And further to that point within the PBM space, every PBM has figured out a way to get that insulin preferred on their formulary and get that $35 insulin to their members. So the idea that we won't go after the low-cost product, that's not true. The one comment I would have to your question that I would say is not really accurate, our contracts with payers are performance contracts. And performance in the PBM space as it relates to payers means getting them the lowest net cost for the drug. So we have to deal with the high list prices that the manufacturers set because only they can set them, but we use market tools and market leverage to ultimately get those prices lower so that that's the lower price that the benefit sponsor and the consumer actually pay. So our contracts are driven, we profit, we make money when we provide the lowest net cost for each of the products, not when we provide the highest. Think about that. If you were going to put out an RFP to build a road, would you award it to the person who added $1 million cost to the building of that road, or would you award it to the company that took $1 million out of the cost of building that road? That's what we do. We do not add cost to the system. We reduce the cost, the initial cost of the product. Do we make a profit when we do that? Do we make money when we do that? Yes, we do. We're a business. If we did this and didn't make money, we wouldn't be a business, we'd be a charity.
Thank you. In lieu of time, we will entertain the next three speakers. Senator Hackett.
Yeah, thank you. Yeah, I just want to ask you a question, gentlemen, at the end. In Ohio, our big companies are really called the Business Roundtable. And when you look at the rebate, that rebate between the companies is never disclosed. I've been a chair of insurance. We've been trying to get that rebate. The state of Ohio won't give the amount of rebate. So the PBMs do a tremendous job for the big companies. But when you saw that legislation that's pending in federal, it's that all the rebate would go. It's when they get the small, and I realize their costs are higher, but when they did the smaller company, the mid-sized company, you know, they're not giving them the same rebate that they give the major companies. So the PBM is keeping that rebate because they're getting that rebate from the drug manufacturer because it's based on the volume of that. So the question is, well, that legislation, is that the solution? I mean, how do we get out of that problem? Because the big companies don't want to change the system. They love the PBM system because PBMs negotiate for them, and they get huge rebates. But the smaller guy doesn't, and the mid-side, and the PBM pockets that. And I realize, once again, their costs are higher. So how do you react to the rebates that the PBM keeps?
So again, that's a great question, and it draws a level of specificity. The rebate, when a PBM negotiates rebates, they negotiate the rebates with the drug manufacturers for their entire book of business, which includes the large companies and includes the small companies. Each company gets their portion of the rebate as it's allotted to the total slice. So if you're 13% of the total rebate aggregation, you're going to get 13% of the rebates that are negotiated. That's how that works. Many of those mid-sized to small companies are also working through a health plan. So we're taking all of those lives and we're negotiating that, and their contract is not with the PBM, their contract is with the health plan, and their portion of that rebate is negotiated with that health plan. If they don't like that negotiation, we encourage them to go with another health plan or reinvigorate that negotiation or go direct to a PBM. You can, if you're a mid-sized company, you can go directly to a PBM without going through an insurer. But a lot of them go through insurers because the insurers are able to do a lot more for them and they're able to aggregate a lot more of their other benefit issues. So they actually are getting that. The PBMs aren't keeping that rebate. You can't just keep money and not claim it and hide it. That's not how it works, especially with the for-profit PBMs. They have financial disclosures. Every dollar has to be accounted for.
So why does the federal legislation say that all the rebate should pass back to the plans? It doesn't now.
And it does that now. We don't have a problem with that legislation. The fact that you have legislation that says that the 100% of the rebates have to pass through to the benefit sponsor. The only question with 100% of the rebates passing through the benefit sponsor is a lot of those smaller mid-sized companies that don't have the cash available to pay for the quality benefit that they offer their employees will offset payment for that by allowing the PBM to keep 2% of the rebates that they collect for them. And that is a form of payment for them. So if you take that away in the legislation and say 100% of the rebates have to go back to the plan sponsor, we're fine with that, but then that means, as Mitt Romney said in the last hearing, that means that you're now eliminating a flexibility option for that mid-size employer to offer benefits for their employees.
Next, Representative Cheney.
Thank you, Madam Chair. So I sponsored a PBM bill in the state of Florida. So I got pretty deep in the weeds on this stuff. And the one question I never got answered, meeting with PCMA and PBMs like yourself, is they constantly said that they are not a middleman, that they provide a service to reduce drug costs for the consumer. Yet drug prices have gone up 180%, and 3 PBMs control 80% of the market and are number 5 and 6 on the Fortune 100 list. So how can you say that you're, one, not a middleman because you don't manufacture, You don't warehouse, you don't touch the product. You're basically pushing paper, negotiating that appears to be for the benefit of your profits, not the discount to the consumer based on how drug prices have increased and how your value as a company has increased. So my first question is, so what is a PBM? If you're not a middleman and your purpose is to reduce costs to the consumer, yet there's no evidence of that, help me
Sure.
with that.
So I would go back to the presentation that we saw earlier from the first presenter, in that we are a middleman. I don't shy away from that, but I don't use that term with the derogatory intention. We are in the middle between the consumer and the manufacturer and the pharmacies. So yes, we are in the middle, and we aggregate those lives, and we negotiate with manufacturers and pharmacies to create networks and to create prices for those drugs that ideally are sustainable. I might ask that question another way. So looking around this room, there is not a single state that's represented in this room, either here at the dais or behind us, that hasn't passed some version of the bills that we just listed off. And many of the states have had these versions on the books now, versions of these bills, and many of them, multiple versions that have passed for 3, 4, 5 years. And I agree with you. Prices haven't gone down. I agree. This year alone, the manufacturers in the first quarter of the year did what they always do, and that is the top 25 manufacturers came out with the top 200 drugs that they raised the price of between 9 and 15% across the board. I agree with you. But that has nothing to do with us. We take that raise, we take that price, and we negotiate with the manufacturers, with the lives that we have, to ultimately have payers and consumers pay a lower price other than what they've said is the list price. So I think we do our job well. If you want to look at a world where, if you want to look at it, try looking at modeling a world where there isn't anyone between your pocketbook and pharma.
Follow up, Madam Chair? Thank you. So with the rebates, that you require the drug manufacturer to add on top of the cost of the drug that goes to the PBM, how is that reducing drug costs for the consumer?
Sure. Well, first of all, we don't require the rebate. The rebate is offered to the PBM, and it's a wry
Isn't
smile.
that required to be on the formularies, though?
I'm sorry?
Don't you require that to be put on the formulary?
No, we do not. And the case in point will be the 3 insulin drugs. Those 3 insulin drugs will not have rebates. They'll be $35. They'll be the lowest net cost, and they'll be the preferred product in those classes. So again, the manufacturers offer us the rebates in order to gain that favor.
Right.
Yes, rebates were a construct of the manufacturers, not the PBMs.
Okay.
They wanted to be able to create that level of preference on the formulary.
One quick follow-up, Madam Chair.
Excuse me, last one. We have to move on. Thank you.
Last one, okay. So one of the biggest battles I had with the bill was specialty drugs, which there's not a definition for specialty drugs. Best we could tell, specialty drug means that it's a high-priced drug with a high profit. So our bill defines specialty drugs, but if the PBM, again, is focused on lowering drug prices, why fight so hard to protect the margins in the specialty drugs?
Because the cynical way that specialty drugs were defined is not really accurate. So there are some definitions for specialty drugs. CMS has a specialty drug definition that talks about price, it talks about storage, it talks about the issues that center around the utilization of the drug. And so any drug on a specialty drug list is dependent upon all of those things. What kind of administration does it require? There is a price component to it, the shipping, the access to the product, and then ultimately it's a product of the decision between the benefit sponsor. There are different benefit sponsors in this room represented by the various state health plans, where you will have a drug on one state health plan that will not be considered a specialty drug, but that same drug on another state health plan will be considered a specialty drug. And that is not a product of the PBM, that is a product of the health plan's decision and how they created their formulary. So we administer that formulary.
Thank you. And we have two presenters following, so this conversation has been very beneficial. I am going to follow up personally with it. And next, we'd like to thank our presenters for, we really appreciate you joining us and giving us this valuable information. Now, next on our agenda is a presentation on Minnesota's basic health program, which will focus on the basic health program is which state have them and which has them and which have not worked for these states. Kind of twisted there. So in your binders on page 51 is some background information that you might want to look at for this presentation. This is also on the conference app and website. With us here today is Julie Marquardt of the Minnesota Department of Human Services. We'll hold all questions until Julie is finished. Julie, please go ahead.
Thank you. I feel bad interrupting some good conversation on drug pricing, so this is going to take a little left turn for y'all. So thank you for having me. I am going to speak to our basic health program in Minnesota. Its name is Minnesota Care, and that would be the name that all Minnesotans know it by. Most Minnesotans don't know it's a basic health program. Just to go back to the history of Minnesota Care, the program itself predates any federal opportunities for having basic health programs. The program was originally established in 1992. It was established as a subsidized program. It was for families who were making too much to qualify for the state's Medicaid program, but were really still struggling to afford health coverage. It had bipartisan support. It was established under a Republican governor with bipartisan legislative support, and it has enjoyed quite a large amount of bipartisan support since then. It is a statewide program. It is offered in all 87 counties in Minnesota. If you don't know Minnesota, there's kind of 7 counties that are considered our metropolitan area, and then there are 80 counties that are often referred to as Greater Minnesota. The population that is served, more than 50% are in Greater Minnesota that are served by this program. So it has a large reach across our entire state. In 1995, the Center for Medicare and Medicaid Services, which was HCFA at the time still, allowed states to operate under a waiver. And so we were able to bring this program under a waiver. So instead of having all state funds, we were able to finally get some federal Medicaid matching funds. It didn't cover all the population, but certain populations we were able to receive some federal funding to help support the program. Ultimately, it was a program that covered children and families that otherwise could not get coverage, but it expanded eventually over time to include adults without any children. As I mentioned today, it operates as a basic health program under federal law. We established our program in 2015. We were the first to establish our program. New York also established their program in 2015. But we launched ours a little bit ahead of theirs. It is a state and federal program. It is not part of our Medicaid program. It operates under a different authority. And I just gave for reference the section of the Affordable Care Act that authorized this. And it allows states to purchase coverage directly for people. The way that it's funded is by pooling the premium tax credits and cost-sharing reduction subsidies that they would have otherwise received had they gone through the exchange. As I mentioned, there's 2 states, it still is Minnesota and New York, who operate basic health programs. Excuse me, and I mentioned for now, because Oregon is a state that is looking to expand and include a basic health program. And so I know that work is underway and that study is underway. There have been other states that have studied it. I don't know that there's any state other than Oregon that's getting close. But there have been states who have an interest in setting up basic health programs. So going back to the population today, it serves more than 100,000 Minnesotans. It is mostly adults over age 18. Many of them are parents whose children may be on our Medicaid program. The income level they are making between 133 and 200% of the federal poverty guidelines. And just to give a context, for an individual, that's somebody making no more than $27,180 annually, and for a family of 4, they are not making more than $55,500 annually. The coverage that we offer under our Minnesota Care program is comprehensive. It has additional benefits that are not typically available under most of the individual market plans. We do have to cover the essential health benefits, the 10 benefits that are offered in the market plans, but we also have dental for adults and children. We have eyeglasses coverage, and we have a broader array of behavioral health benefits than a typical exchange product would. This program offers low cost sharing. We have a 94% actuarial value. And certain populations are exempt from any cost sharing. So that would include, for instance, children under age 21, American Indians or Alaska Natives are all people who are exempt from cost sharing under the program. The way that the services are offered is through our managed care organizations that are contracted with our department. This is required under the BHP regulations. You have to offer it in kind of a managed care construct. Also within the regulation, we have to offer at least 2 health plan choices to individuals on our Minnesota Care program. We have 9 health plans that are currently contracted with us. There are 5, and Minnesota has a broad array of health plans that do business in the state. We have 5 licensed private HMOs. We have 1 licensed county-owned HMO, which is Hennepin County, our largest county. And then there are 3 county-based purchasing organizations that offer a county-based purchasing plan, and that exists in 33 rural counties. And so there is a wide array of options for people to choose from. We leverage our Medicaid contracts, and we negotiate this as part of those offerings. But this is operating as a separate program, but it includes the same organizations that we contract with in our Medicaid program. As I said, the financing comes from the state and federal government. For the federal funds, as I said, it's 95% of the tax credits that would otherwise be available to those individuals. With state funds, the state has a healthcare access fund, which is funds that are derived essentially from a state tax on hospitals and other providers. We also have to use state funds to pay the administrative costs to operate the program. So those tax credits that we draw down from the federal government cannot be used to pay for any of the administration that we have to operate the program in our state. So our healthcare access funds, which are derived from those tax sources, are what we use to fund our administration. And then there are enrollee premiums. That's the third source of financing for the program. And that is based on a sliding scale and ranges from $0 to $80. And I have January of 2024 there because during the public health emergency, we charged no premiums, and our legislature last session extended that through our resumption of renewals for Medicaid, because Minnesota Care, when we kept continuous coverage, Minnesota Care was included in that continuous coverage, so we are restarting renewals for our Minnesota Care program this year too. But we will not be charging premiums until January of 2024. So there is a lot of learnings that continuously go on with our program, and a lot of it is just to understand the marketplace and the populations. And that changes. That has changed over time. It's changed a lot since 1992, and it's changed a lot since 2015. And really figuring out how does the BHP fit into our marketplace. Really understanding who are the uninsured populations. What does your Medicaid program coverage look like? Each state has different Medicaid programs that cover different populations with different benefits. So really understanding who's left out there when you've put together your individual market, your Medicaid program, and then what are you trying to accomplish with it? And then financial considerations and relationships, knowing that you have to cover administrative costs. How are you going to do that? What is the impact of bringing BHP into that continuum on the individual market? What does that do to your Medicaid program? And trying to understand that and mitigate any unintended consequences if you can. Then there's a whole question about benefit design. What benefits are you going to offer? There's the 10 essential health benefits that you have to offer. But when Minnesota stood our program up, I would say it is more like a Medicaid benefit. We kind of leveraged our Medicaid benefits and our rates. But New York perhaps has leveraged more of a commercial in their marketplace versus using some other metric. You could use Medicare as a metric. Essentially, you have to provide those essential health benefits, and then you have to market to a benchmark plan. And there are a variety of options for benchmarking. The one that Minnesota happens to use is the federal employees program. And then you have to determine cost sharing. And 94% actuarial value is the lowest that you can go, so Minnesota has adopted the highest amount of cost sharing that we can apply. But that's a consideration of also, we have some benefits that don't have cost sharing that apply to them as well. So anyone who accesses certain benefits will not have cost sharing that applies, and many of those are in the behavioral health spectrum of care. With anything, there are opportunities. So there are economies of scale. In Minnesota, we leverage our Medicaid program. In other states, they may consider leveraging their marketplace infrastructure. But one way or another, you have to create, you need to be able to negotiate rates with health plans. You need to have an infrastructure where you can do benefit design, where you have policy development. But that can exist in other places than a Medicaid program. It's Minnesota used our Medicaid program infrastructure to really leverage our operations for our basic health program. But those are the things we have centrally. We operate the Minnesota Care Program out of our department. So unlike our Medicaid program, which is kind of distributed to the 87 counties, so eligibility occurs there, for the Minnesota Care Program, it's centralized at our department. And that was just a decision that was made for efficiency, to make the administration cheaper to operate. As I said, we leveraged our purchasing power with our health plans and negotiate with those 9 health plans, both for their business and Medicaid, alongside their participation in Minnesota Care. And then policy development. We think about whenever new benefits come on to our Medicaid program, we have to think about what does that mean for Minnesota Care. Are we going to include that coverage in Minnesota Care? If we make rate changes in our Medicaid program, is that going to impact the cost of our Minnesota Care program? And if it is, then we have to factor that in. And so sometimes we do make strategic different decisions about things to cover because understanding the populations, the Minnesota Care population is not the same as our Medicaid population. So it's not an automatic that everything we cover in Medicaid is covered in our Minnesota Care program. It is not.
Excuse me,
go
Julie.
ahead.
Unfortunately, I have to give you a 10-minute warning.
Okay.
Thank you.
We're almost. Then, as I said, we aligned our programs so that people who move from one program to another, as families' incomes change, they see the same health plans that are available. And if in a perfect world, we would align Medicaid, our basic health program, and the individual market, so someone can move across and find the same health plan available to them. That would be ideal. We have a lot of overlap. We're fortunate in that way that people do find those options. Between Medicaid and our basic health program, there is a tremendous amount of overlap. So that is something we're very fortunate to have. There are opportunities to expand to other populations. Once you have a program stood up, Minnesota has used the program to expand to some of our undocumented residents in Minnesota. We offer coverage under Minnesota Care with state funding and premium payment and cost sharing to people who are covered under DACA, for instance. There is also a great amount of conversation in our state around public options, and does the basic health program fit into that? That we don't have that today. That is not something that's offered, but there is a lot of conversation. It comes up almost annually as a question, and we are doing some research and study to help policymakers and legislators know what the options might be, what those costs might look like, and choices that they may have available to them. And then it's, for us, it just becomes part of improving the health overall in our state. Really working to help lower our uninsurance rates. We enjoy a low uninsurance rate. We hope to continue to enjoy a low uninsurance rate. And also improving access to care. People have affordable coverage that they can actually go and use. And then this is kind of my last slide, because and these are just two quotes from people who are on our Minnesota Care program. We had put out a publication a few years ago that included information on our Medicaid program and our Minnesota Care program. And I'm not going to read them to you, but essentially, this program is covering entrepreneurs, it's covering farm families, it's covering people who work jobs that maybe don't have employer-sponsored coverage, or people who are working several part-time jobs, so they don't qualify for their employer-sponsored coverage. So to us, we can build any program and we can get everything we think is right, but if the people who it serves don't like it or don't think it serves them well, then it's not a success. And so the quote on the left is actually from a woman who is married to a farmer, and the importance of that program to making sure their family had coverage. And the quote on the right is from a person who works multiple jobs, likes all of them, can't get in coverage from any of them, so this program fits in. And so it's not, as I said, this isn't the Medicaid population. These are folks who are working, and some of them working really, really hard, and they're important in their contributions to the state. So I just wanted to make sure we gave them kind of the final word here.
Thank you, Julie, for that wonderful presentation. And we have time for one question.
Ooh, make it a good one.
And this Representative LaBeouf.
Thank you. I'm from Massachusetts, so obviously this is, we've got a little bit, but I'm curious, especially with the Medicaid redeterminations. We don't have county systems. Our counties really don't mean anything. Everything's centralized, but I'm curious how that's functioning, and what role does this plan play in regards to kind of helping that population out?
Thank you. So, right, as we restart, and every state, again, is doing redeterminations differently, right? So Minnesota is doing our Medicaid population in 12 cohorts. So we're doing one cohort per month over a 12-month time period. Minnesota Care will all renew all at once, just like they always did. They were always for January 1st coverage. So what will happen during our redetermination periods are, we're going to have families, I'm certain, whose income has changed in the last 3 years, who now may become eligible for Minnesota Care. So if they are redetermined, let's say in this month, they were to be redetermined eligible, they move on to the Minnesota Care program, and then we'll have a redetermination back again in November. But that will happen. It will originate from the state and come back to the state. There's a lot of coordination we have to do between counties and the state of Minnesota. And we have a really good working relationship with our 87 counties to make all of this work. So you do have to coordinate because families move between these two programs. But there is going to be a difference for how that fits in. But we will see people move on to the Minnesota Care program until we reach that redetermination for all of Minnesota Care. And then we'll see some Minnesota Care people move off of that program who may have received employer coverage during this time period too.
Thank you, everyone, and thank you, Julie, for being here. We really appreciate it. Last on our agenda is a presentation on the recent proposed regulation from the Internal Revenue Service that deals with captive insurers. In your binder on page 54 is an opposition letter that NCOIL submitted to the IRS that you may wish to look at. It's also on the conference app and website. With us here today is James Kendricks of the Independent Community Bankers of America. We will hold questions again until he's done. James, please go ahead.
Thank you very much, and thank you for having me. I think I'm holding up lunch, so we'll try to make this as brief as possible. I do feel a little strange here. They get to talk about drugs, and I got to talk about the IRS, so this will be a little bit different avenue. Minnesota is a very fitting place for us. We are an advocate for small banks, and Minnesota is the birthplace of small banks fighting back against much larger institutions. So this is a very important place for us. So again, thank you for having me here. We're talking about captive insurance transactions. You may or may not know that the IRS is looking for money, and we're $32 trillion in debt and probably going higher soon, and so they're looking for any way to expand upon sources of revenue with taxpayers. And small banks are in the crossfire there through captive insurance companies. So small banks set up captive insurance companies are formed by the banks. They create a sub. They generally are set up to protect against unfunded risks. So you think about cyber risk, you think reputation risk, fraud risk. There are insurance policies there all over the country through different issuers for those types of risks. But there are many different reasons why a small bank can't be involved in those products. Either they're very expensive, there's a hurdle to getting to those products, and various other issues there. So the banks want to cover unfunded risk. There's a piece of the tax code that allows for that. The bank can set up what's called a captive insurance company, and there are many other industries and types of businesses that create these insurance companies. The bank pays the premium to the insurance company. The bank can take a tax write-off for that premium. It's paid to the child entity, and the child entity is not taxed on that premium. They're only taxed on the investment income. That's Section 831 of the Internal Revenue Code. Anyone's interested, but that's sort of where we've been thus far. This industry has become much larger. There are a lot of third-party players that have encouraged and assisted many different banks in getting involved in these types of activities. And again, banking is it's not a high-risk business, but it's a managed risk business, and risks are always there, so insurance is very important. So, of course, Treasury and IRS have concerns. They're always looking for abuse, and the IRS has come out and said that these transactions between the bank and its related party could be considered a micro-captive transaction, and as such, it could be what's called a listed transaction of interest. And so when it becomes flagged as that type of transaction, you have to report it. You have to tell the IRS that you're engaging in that transaction. If you do not report to the IRS, of course, there could be penalties involved, and that's never good. So IRS came out with a notice that basically said if if your premiums don't cover 70% of the losses, you could have what's called a listed transaction or transaction of interest, and you have to report that. Of course, this was fought very harshly in the courts. For those of you that don't know, at the federal level, there's something called the Administrative Procedures Act. Every federal agency that wants to come out with a rule has to propose the rule. They have to allow for public comment, and then they have to take the public's comment into consideration and issue a final rule. Of course, the IRS did not do that when they issued these notices, so there are some key court cases here. Mann Construction versus U.S. Sixth Circuit held that when the IRS imposes a new duty on the taxpayer, they have to follow the Administrative Procedure Act, or APA. CIC Services, LLC versus IRS District Court held that this notice that we just mentioned was invalid because it failed to follow APA. So now what we have is that the IRS has come around again with an official APA notice, and they basically said that these micro-captive transactions may be listed transactions or transactions of interest. It's really the same as what they came through before, except this time that 70% ratio has been brought down a little bit to 65%. And then, of course, if you're an advisor to a taxpayer now, you have to report if you've got one of these listed transactions or transactions of interest. So really interesting, dry stuff, unfortunately, on the IRS. I think where it does get a little hopeful is that you all have sent comments on this. We've sent comments on this. This is a big deal. Obviously, if you think about a community bank, it's a managed risk business from a lot of different aspects, but your catastrophe, so to speak, or your risk events don't happen on an annual basis. For example, if you're insuring against cyber risk, you may go 2, 3, 4, 5 years with no cyber events, and then you could have one big cyber risk event that comes to fruition, and that's why you have the insurance, right? It's the rainy day fund, so to speak. So we've been very vocal on that front. You know, again, from the standpoint of a small bank, these are very small enterprises. Many of them are family owned. They've been in business for 100 years or more. They're not trying to cheat anybody. They're not trying to make a huge profit. They're just trying to serve the people in their specific area. And you know, this is really straightforward. There's no need for all of this craziness with getting involved with the tax code for tax items that have been around since the 80s. So that's kind of where we are now. There was a hearing yesterday on this. The notice of proposed rulemaking, the time limit is up on that, so they'll be issuing a final rule on that, and hopefully they will consider our comments here. With that, any questions or concerns?
Well, thank you, James. And now I'll open up for questions or comments from the legislators. There's none?
No one wants to talk IRS?
It appears to that way. So once again, we would really like to thank you. We really appreciate you being here.
Thank you.
Well, I have one more piece of business to address. You may have seen the news last week that the Federal Department of HHS, Treasury, and Labor have released a comment proposed legislation dealing with issues such as short-term limited duration and fixed indemnity plans. In 2016, similar regulations were proposed, and NCOIL submitted a comment letter which you can view on the website and on the app. Also in 2020, NCOIL adopted a short-term limited duration insurance model act. Accordingly, following this conference, NCOIL leadership and staff will review the proposed regulations, and it is likely that NCOIL will comment in some manner. It is also possible that NCOIL Health Committee will hold an interim Zoom meeting in September to discuss the proposed regulations and their implications. If you have any questions on this, please reach out to NCOIL staff. Is there any other business before this committee? Well, before we adjourn, I'll note that next up is the Institute's Griffin Foundation Legislative Luncheon, which is held on this floor in the Elks and Deer Room. And please, be back in this room at 2 p.m. sharp for the Health Committee. That committee's agenda is very busy, and we really appreciate you keeping on schedule. Seeing no more business, this meeting is adjourned.